Welcome to this training on post-traumatic stress disorder, PTSD, in the context of EMS. In this session, we will explore what PTSD is, how it differs from acute stress reactions, and how it impacts our patients, including civilians and combat veterans. We'll discuss how you, as EMTs and paramedics, can recognize PTSD in the field and apply appropriate care strategies. This is crucial for us because EMS personnel are often first to interact with individuals in crisis, some of whom may be living with past traumas. By the end, you should feel more confident in identifying PTSD related behaviors and tailoring your approach to keep both the patient and yourself safe. No matter where you work, urban, rural, civilian population, or near a military base, these skills are increasingly important. Let's begin by outlining what we'll cover. Let's start with a definition. Post traumatic stress disorder is essentially a prolonged and severe stress reaction to a terrifying event or ordeal. This could be experiencing or witnessing something like a life threatening accident, a natural disaster, war combat, or a violent personal assault. During such events, people feel extreme fear, horror, or helplessness. That's normal at the time. PTSD occurs when, after the fact, those intense feelings and responses don't resolve and instead persist or resurface long after the danger has passed. Importantly, PTSD is not just a military issue. While it gained public attention due to combat veterans, it can affect anyone. For example, survivors of car crashes, sexual assault, or childhood abuse can all develop PTSD. In fact, common causes of PTSD in the general population include things like serious accidents, natural disasters like hurricanes, violent crimes, or the sudden loss of a loved one. So when we arrive on scene to, say, a major car accident or a domestic violence call, we might be treating not only physical injuries, but also people at risk for psychological trauma. But how common is it? In the general population, studies show about 7 to 8 out of every 100 people will have PTSD at some point in their lives. So, in a typical community, PTSD is relatively common. Most people will go through at least one traumatic event in life. In fact, about half of women and 60% of men experience trauma at least once. But thankfully, not everyone develops PTSD. There are factors that determine whether trauma leads to lasting PTSD. We'll cover those in a minute. Now, among combat veterans, the rates are higher. Different studies vary, but roughly 10 to 20% of veterans from recent wars, like Iraq and Afghanistan, have PTSD in a given year. For Vietnam veterans, about 15% were diagnosed in one assessment, and for Gulf War veterans, around 12%. Essentially, military service, especially combat, carries a greater risk for PTSD than many civilian traumas, due to the intensity and repetition of traumatic exposure. So, as EMS providers, especially if you serve a community with many veterans, you will likely encounter patients with PTSD related to combat. We'll talk more about veterans specifically later because they do have some unique considerations. It's important to distinguish acute stress disorder, ASD, from PTSD because you might encounter patients very soon after a traumatic event who have intense symptoms, but it hasn't been long enough to call it PTSD. Acute stress disorder is essentially the immediate aftermath of trauma. With ASD, the person's symptoms show up within days of the trauma, at least by 3 days, and can last up to about a month. During this acute phase, people often experience many of the same reactions as PTSD, nightmares, flashbacks, anxiety, but a hallmark of acute stress disorder is the presence of dissociative symptoms. Dissociation means the person feels disconnected from themselves or reality. They might describe feeling numb or like things are unreal or as if they're watching themselves in a movie. For example, someone might say, I felt like I was in a fog, or it was like I wasn't even in my own body. This can manifest as being in a daze, not fully aware of one's surroundings, or having memory gaps about parts of the ordeal. In acute stress disorder, these dissociative feelings are common and are part of what sets it apart from PTSD. PTSD, on the other hand, is more of a long-term condition. The rule of thumb is the 1 month mark. If the post traumatic symptoms, like intrusive memories, avoidance, etc., last more than 1 month and meet certain criteria, then we classify it as PTSD. It can start right after that 1 month point, or sometimes there's a delayed onset. A person might seem okay for weeks or months and then develop PTSD symptoms later. But timing isn't the only difference. It's also about persistence and severity over time. Think of ASD as the body and mind's initial shock reaction. In many people, these acute symptoms will gradually resolve over a few weeks. That's the normal recovery trajectory. In fact, most people who experience trauma have some stress reactions initially, trouble sleeping, feeling on edge, etc. But the majority will recover with time and support, not developing PTSD. However, in some cases, those symptoms don't resolve and instead can even get worse, leading into PTSD. The presence of dissociation early on is something to note. If someone has acute stress disorder with dissociative symptoms, some studies suggest they might be more likely to develop PTSD later, though it's not guaranteed. Essentially, acute stress disorder can be a precursor to PTSD. If you encounter a patient days after a trauma and they're highly distressed, your care and referral for follow up can be crucial. Early intervention, such as psychological first aid, ensuring they have support, might help prevent the progression to full PTSD. From an EMS standpoint, you won't be diagnosing these conditions, but it's useful to understand the timeline. If it's been only a week since a major car crash and your patient is panicking and in a daze, that's likely an acute stress reaction. Our approach would be supportive, keep them safe, grounded, and encourage them to seek further mental health care. If you're seeing someone months or years later with similar panic and flashbacks tied to an old event, that's when PTSD is the more likely issue. So, what kinds of experiences are we talking about when we say trauma in the general public? Traumatic events capable of causing PTSD are typically those that involve the threat of death or serious injury, or witnessing something horrific. Think of events that would terrify or overwhelm almost anyone. Violent assaults. Unfortunately, things like sexual assault, rape, or physical assault are major causes of PTSD. For instance, a survivor of rape may develop PTSD, reliving the assault in nightmares or feeling intense fear when reminded of it. Domestic violence victims, say a woman beaten by her partner, can also develop PTSD symptoms even long after escaping the situation. Accidents. A bad car crash can precipitate PTSD. We, as EMS, see car accidents frequently. Imagine a multi car pileup where someone sees others badly injured or thinks they might die. Surviving that, they might later have flashbacks while riding in a car. Industrial accidents or other on the job accidents can have a similar effect. Natural disasters. People who live through hurricanes, tornadoes, earthquakes, floods, especially if they saw people get hurt or feared for their own life, sometimes come away with PTSD. For example, survivors of a building collapse in an earthquake might panic whenever they feel a rumble or hear a loud rumbling noise. Sudden loss of loved one. Grief is normal, but if someone witnessed a traumatic death or found a family member who died violently, that can cause PTSD. Even learning about a traumatic death of a close friend or family member, like hearing a loved one was murdered, can lead to PTSD in some cases. These are just examples. Essentially, any extremely stressful, life threatening, or violent event can be a trigger for PTSD. Importantly, it could be direct or indirect. That means you might develop PTSD not only from what happened to you directly, but also from witnessing something happen to others, or even from repeated exposure to trauma details. For example, crime scene investigators or emergency workers who deal with trauma regularly. In EMS, we are among those who have repeated trauma exposure. More on that in a moment. Now, not everyone who goes through trauma develops PTSD. In fact, most do not. As mentioned, about 7 to 8% will get PTSD in their lifetime, whereas over 50% experience trauma. So there are factors that influence whether a given trauma leads to PTSD. The severity and duration of the trauma is a big one. If someone experiences a trauma that is especially horrifying or prolonged, for instance, ongoing child abuse versus a one-time incident, the risk of PTSD is higher. Multiple traumatic events over time can compound the risk as well. This is sometimes called cumulative trauma. For example, a person who has a history of childhood abuse and then later becomes a victim of assault might be more likely to develop PTSD after the second event than someone with no prior trauma. Physical injury during the event can also increase PTSD risk, partly because injuries add additional stress and pain, and recovery from injuries can serve as constant reminders of the event. A personal or family history of mental health issues can make someone more vulnerable. If a person already struggles with anxiety or depression, or they have a history of trauma in childhood, they might have fewer coping reserves for a new trauma. Also, people who have a family history, say a parent with PTSD or other mental illness, might have genetic or environmental factors that increase risk. Social support is critical. A person who has caring friends, family, or community support after a trauma is less likely to develop long-term PTSD than someone who is isolated. Imagine two people who survived the same disaster. One has a strong family and maybe access to counseling. The other has nobody to talk to and tries to cope alone. The second person is at higher risk for PTSD. Substance abuse can worsen outcomes too. Some individuals cope with trauma by drinking heavily or using drugs, which can interfere with recovery and sleep, possibly exacerbating PTSD symptoms. One risk factor especially relevant to us in this room: having a job that exposes you to trauma regularly. This includes first responders, EMS, fire, police, healthcare workers in emergency settings, and of course, military combat roles. We see a lot of difficult things, and while we try to remain professionally detached, we're human. Repeated exposure to others' trauma can sometimes result in PTSD for responders too. In fact, there is research indicating EMTs and paramedics have higher rates of PTSD symptoms than the general public. One number I've seen is around 15% for EMS providers versus approximately 6% general. So, yes, PTSD is not only something our patients deal with, it can affect responders as well. That's just a point of self awareness. If you feel impacted by traumatic calls, it's important to seek support for yourself as well. Now, let's focus on combat veterans and PTSD. While civilians can certainly have PTSD, as we've discussed, combat veterans are one group we encounter that often has significant PTSD triggers and needs that we should be attuned to. In a war zone, service members may go through multiple traumatic events. They might face enemy fire or roadside bombs regularly. Surviving an IED explosion or an ambush, especially if it happens more than once, is extremely traumatic. Many see fellow soldiers or civilians wounded or killed, which can be as traumatic as personal danger. The loss of comrades in combat can leave deep psychological scars. Survivor's guilt is common. Some are held in fearful, high alert states for long periods. Imagine being deployed on patrol every day, not knowing if today's the day you'll be hit. That chronic stress primes the body for PTSD. There's also the reality of moral injuries or atrocities, witnessing or sometimes being forced into situations that conflict with one's moral values. For instance, seeing civilian casualties or handling dead bodies can contribute to PTSD. Because of these intense experiences, it's not surprising that the prevalence of PTSD is higher in veterans. One key point is the cumulative impact of multiple deployments. Many service members nowadays have done several tours. Each deployment could involve new traumatic exposures, essentially compounding trauma on top of trauma. Evidence suggests that the more time someone is sent to combat, especially without adequate rest and mental health support, the greater their risk for developing PTSD or other stress-related issues. It's as if the stress cup fills up more and more with each tour until it overflows. Besides the sheer exposure to combat, other risk factors within the military context can influence PTSD development. Being physically injured in combat, for example, shot or hit by shrapnel, is traumatic in itself and also adds a recovery period that can remind the person of the trauma. Every pain or surgery is a reminder. Rank and role. Some research, mostly from analysis of risk factors in military, indicates that those of lower rank or education might have higher PTSD rates. This could be related to the amount of combat they see. Infantry enlisted personnel often see more frontline action than officers in some cases, and possibly less access to support or coping resources. Unit cohesion and support. A veteran who had a strong unit support system might fare better than one who felt unsupported or had leadership issues. Camaraderie can buffer stress to some extent, whereas isolation exacerbates it. Prior life trauma. Interestingly, a service member who had traumatic experiences before the military, like childhood abuse or other trauma, might be at higher risk of PTSD after combat compared to someone with no prior trauma. It's as if they already carry some scars that can be reopened or compounded by new trauma. Military sexual trauma, MST. Although the slide doesn't explicitly list it, it's worth noting that for female veterans and some males, sexual assault in the military is unfortunately a reality and can cause PTSD either by itself or in combination with combat exposure. MST is a significant contributor to PTSD among women veterans. Also, veterans often have co-occurring physical conditions. One big one is traumatic brain injuries, from blasts, concussions, etc. A large number of recent combat vets have mild to moderate TBIs. This is important for us to know because a patient with a history of TBI and PTSD might have additional cognitive difficulties, memory issues, impulsivity, or may not respond to stress in the same way neurologically. Let's wrap up this lecture here. Join me on the next one as we dive into how PTSD manifests in the patients we may encounter. See you then.